Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh and a very good morning. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. So welcome to today's clinical pathological conference. So today is our turn from the Department of Otorinolaringology Hair and Neck Surgery, and we have a very interesting topic today. So together we will unveil a true cause behind a girl presenting with congenital stridor. And we have lined up for you many consultants who will be presenting today. So the history as well as the progress of the patient will be presented by none other than our registrar, Dr. Muhammad Azhar, who is also a UKM alumni. So you all can join our postgraduate program later when you graduate. Yeah. And then we have 3 consultants. So Professor Dr. Goh Bee See, Senior Consultant Otorinolaryngologist and Head and Neck Surgery with subspecialty Pediatrik Otorinolaryngology will later sum up the case. The radiological findings will be presented by Associate Professor Dr. Faizah Muhammad Zaki, Consultant Pediatric Radiologist. And then the histopathological examination findings will be presented by Associate Professor Dr. Suria Hayati Muhammad Pauzi, Consultant Pathologist. All 3 are my teachers as well as my friends. So I'm sure you all will benefit from this presentation, not only for the medical students, but also for the medical officers at the postgraduate level or even giving services. Yeah? So this is a very important topic. So without further ado, I would like to invite Dr. Muhammad Azhar to start the case presentation.
Thank you, Prof. Mohd, for kind introduction. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh and a very good morning. I bid to all the professors, lecturers, my teachers and not to forget members of the hall. So I will be presenting on the first part of the clinical pathological conference today, and this is the outline of my presentation. So we have a 5-year, 5-month-old girl who presented with intermittent noisy breathing, which occurs soon after birth. Initially, the parent was not too sure on the exact onset of the symptom. However, they reported that the symptom of noisy breathing started soon after the birth. Symptom was initially intermittent in nature and worsened at the age of 2. At that time, it was associated with painless swelling on the left neck, which was increasing in the size. There were associated symptoms of drooling, snoring, and episodes of apnea, in which it was worse on supine position. There were no symptoms to suggest infective causes of the stridor, for example, fever, barking cough, and rapid breathing. No weak cry at birth. No cyanotic episodes or interrupted feeding at home. There was no history of intubation or aspiration symptom. Child was brought to seek treatment in multiple centres. In the first 6 months of her life, she was treated as bronchitis by multiple general practitioners, and at the age of 6 months up till 2 years, she was seen by a pediatrician and treated as laryngomalacia. However, symptoms persist despite the treatment given. There was no significant past medical or surgical history, and there was no known allergy. In terms of birth history, mother had dual uterus with uterine cyst and gestational diabetes mellitus. She was born full term via vacuum-assisted spontaneous vaginal delivery with birth weight of 3.36 kg. Postnatally, she was admitted to neonatal intensive care unit and treated for neonatal jaundice, requiring phototherapy for a week. He completed her immunization, in which her immunization is up to her age, and her developmental history was corresponding to her age at the time of presentation. She is the first child in the father's second marriage. She had 2 other siblings from the father's first marriage, in which both of them are healthy. Parent denied any similar problem in the family, and the father is working as a contractor, whereas the mother is a civil engineer and they live in Kuching, Sarawak. So now we go into the physical examination. So on general examination, patient was alert, conscious, there was no dysmorphic features. Her current weight at that time was 10.2 kilogram, which is about 5th centile. There was presence of inspiratory stridor, subcostal recession, intercostal recession, and suprasternal recession with pectus excavatum. Vital signs were stable with saturation under room air about 97%. There were multiple cafe aule spots seen on her trunk, right axilla, right hand, as well as the right knee. So now I will show the video of the child, in which, for the benefits of our audience today, especially medical student, I would like you all to listen to the noisy breathing in this child. Okay, if you listen carefully to the video that I have shown, there is a noisy breathing on expiration, if you can appreciate, and the noisy breathing is actually high pitch. So this is an inspiratory stridor. So I will play one more time for about a few seconds for you to appreciate it again. Okay, so on neck examination, there was multiple lobulated swelling in the left level 2 and 3 region, measuring about 4 times 4 centimeter. It was non-tender, not erythematous, mobile, soft in consistency, and there was no attachment to the overlying skin or deep structure. Intraoral examination, there was no trismus, there was ruling, no intraoral mass or any medializations of the lateral oropharyngeal wall. The other examination includes ear as well as the lung examination were unremarkable. Now I would like to show the flexible scope.
So can I just stop you there, Dr. Azhar? So can we call upon one of the registrar to probably volunteer us some provisional and differential diagnosis at this point? Maybe we can have Dr. Shalina. Shalina can just come here. Just come here. Yep, quickly. So we will ask Dr. Shalina to give one provisional diagnosis and 2 differentials at this point. So yeah. So you already listened to the history, and you already listened to the physical examination findings. So if Dr. Shalina has some history of physical examination to clarify, you can clarify with Dr. Azhar and then offer your provisional and differential diagnosis. Do you have anything to clarify, history and physical examination? To remember one step nearer to the microphone.
I just want to reconfirm. So it's a 2 years old, history of laryngomalacia, and have inspiratory stridor. However, there is no failure to thrive, there is no cyanosis, right? And she has a neck swelling.
Okay.
Yes, she is 5 years old.
5 years, okay.
So what's your provisional diagnosis in this case? Before the scope findings.
Okay. So she's 5 years old, and there is no any history of intubation before and no weak cry. And however, she presented with inspiratory stridor, and also there is a neck swelling. So I'm thinking of infected brachial cyst.
What about 2 differentials that you would consider at this point?
Vallicular cyst.
Okay. One more.
No history of intubation, right? Sorry.
No
history of intubation.
So, vallicular cyst, Dr. Shalina, usually happen in the adult age group, right? So, for children, because this patient has stridor since birth.
Stridor since birth. Laryngomalacia, they normally up to 2 years. So, I'm thinking maybe a subglottic stenosis or a hemangioma, since they have cafe aule spots.
Okay, thank you, Dr. Shalina. So I think I agree with your provisional diagnosis of infected branchial cyst, because you're trying to tie up the neck swelling as well as the presence of the stridor. However, your 2 other differentials, we need to work on that. So because this patient has afebrile stridor, even though laryngomalacia is commonly presents after birth, but it can still present at birth. So I think laryngomalacia is one of the differentials that you need to consider. Okay, thank you, Dr. Shalina. Next, can I ask questions to the medical students? Yeah. So now we have this typical history of a 5-year-old girl presenting with stridor since birth. Clinically, there is loud inspiratory stridor and there is a swelling at the neck. So if you are practicing in a as a general practitioner or at the clinic kesihatan, if you see such a child, what runs through your mind? What would you do next? So can I have volunteers from the medical student? Come. What would you do?
Okay. As a GP, I think I would refer to ENT department for, I think, I am suspecting pathology at the larynx.
So what do you think the ENT doctor, ENT MO or ENT specialist would do?
I think they would do a scope.
Thank you. So now for all the medical students and medical officers, even though laryngomalacia is the commonest diagnosis, but we still need to scope these children. So don't presume it's laryngomalacia unless a scope has been done. Okay, so I invite Prof. Razif as a question.
Thank you, Dr. Azhar. Well present. I've heard the history was presented. It's just that I want to know, we would like to know when you mentioned about drooling, and patient already like 5 years old. So can you tell us what is the significance of drooling, and in pediatric, when you want to intervene, and how severe it is? Because if it's drooling, then something blocking inside, and this 5 years already. So can you entertain us about this drooling symptoms? Thank you.
Thank you, Prof. Razi, for the question. So the reason why I asked about the drooling, because drooling is one of the symptoms for example, in acute epiglottitis. So which can also presented with stridor, especially inspiratory stridor in this case. So, however, this child, even though he has drooling, he also have other symptoms such as neck swelling as well as stridor started since birth. So the diagnosis of epiglottitis in child with neck swelling as well as even though she has the drooling is less likely. So if the patient has a diagnosis of epiglottitis, then I would like maybe to proceed with chest X-ray first, provided that the child is stable, to see the typical findings of the epiglottitis on the X-ray of the neck, which is a thumb sign. Yeah. From there, yeah.
Thank you.
Okay, so I think Dr. Azhar can continue with the flexible scope findings.
Alright, so now we continue on with the flexible scope. Okay, so before I explain about the finding, I would like to orientate all the audience. Okay, so on these images that I have paused on the video, I would like to orientate that this is anterior parts, this is the posterior part, this is the right side, and this is the left side. And this image is showing the supraglottic structure. As you can see, this is a part of the free edge of the right side of the epiglottis. This is the right airy epiglottic fold, and you can see a smooth surface mass arising from the left airy epiglottic fold, which partially obstructing the airway. So, and when we see a little bit more here, we can able to visualize the right vocal fold partially on the right side of the vocal fold. So in summary, we have a 5-year, 5-month-old girl who presented with intermittent noisy breathing soon after birth and worsening at the age of 2 years old. And it was associated with painless swelling on the left neck, which was increasing in the size. There were associated symptoms of snoring, drooling, and also observed apnea. Clinical examination revealed loud inspiratory stridor, chest wall recession, pectus excavatum, and multiple cafe aule spots. There were multiple palpable soft lobulated swelling in the left anterior triangle of the neck, and a flexible scope revealed a smooth surface swelling on the left airy epiglottic fold, which was partially obstructing the airway. So now we come to the diagnosis. So this is my provisional diagnosis for this case, which is the vascular malformation. Vascular malformation is a broad term, but specifically in this case, it's most likely either to be a lymphatic malformation, venous malformations, or mixed type. My differentials are, number one, tumor of the larynx, which are neurofibroma, schwannoma, chondroma. Second could be bronchial cleft cyst. And third, which is the most unlikely one, is the laryngomalacia. So now I will go on to the reason why I choose all of these diagnoses. For the vascular malformation, they usually tend to present with a sign and symptom of upper airway obstruction, and the onset of the symptom usually occurs since birth. And when we look into the patient with vascular malformation, they tend to have a soft left neck swelling, which will increasing in the size as the child grow. In this child, she started to have the neck swelling at the age of 2, and it was increasing in the size as the child grow. So that's why we are thinking of vascular malformation. The third one, there is a smooth surface lesion on the left airy epiglottic fold, which can also be presented in patient with vascular malformation. The points again is that in vascular malformation, particularly the venous malformation, there will be bluish discolorations of the lesion that can be seen on the airy epiglottic fold mass on the endoscopy. And in this patient also, there was no history of sudden increase in the neck swelling during episodes of infection, in which mother denied. So this is the 2 points against for the vascular malformation. So for my first differential, which is tumor of the larynx in the pediatric population especially is very rare. But in this case, why I choose neurofibroma is because child had cafe aule. So when when the child have a cafe aule, it's most likely could be a neurofibromatosis, in which is associated with neurofibroma. Otherwise, in general, tumor of the larynx can present with symptom and signs of upper airway obstruction, and they will also have a left neck swelling. And the last one is that these patients have a smooth surface, which is a submucosal. Most likely, it is a submucosal swelling over the left airy epiglottic fold, which more of suggestive of benign tumor of the larynx. So the points again for the tumor of the larynx, number one, is that the onset itself is soon after birth, which is unlikely for the tumor of the larynx. And in this child, the left neck swelling is increasing in its size, which is quite progressively increasing in the size. Usually for benign tumor of the larynx, as for my diagnosis, usually a slowly growing mass. But this child, we observe that the swelling is rapidly increasing over the left side of the neck and cause the airway obstruction. So second differential is bronchial cleft cyst. Patient with bronchial cleft cyst also can present with symptom and signs of upper airway obstruction. They also have a neck swelling, and the typical neck swelling for bronchial cleft cyst, for example, second bronchial cleft cyst is over the anterior border of the sternocleidomastoid, which is also can be seen as this patient had a swelling over the anterior triangle of the neck. So the points again for the bronchial cleft cyst is that number one, the onset is soon after the birth. Usually for bronchial cleft cyst, for example, second bronchial cleft cyst is the common type of the bronchial cleft cyst for our medical student. This second bronchial cleft cyst tend to present at the adolescent or young adulthood. They rarely present soon after birth. Second, if you want to say that this is a third or fourth bronchial cleft cyst, third and fourth bronchial cleft cyst tend to present a bit more later, around at the age of 4 to 12 years old. They rarely presented earlier. And in this child also, there was no history of recurrent neck abscess. Usually recurrent neck abscess history is more suggestive of third or fourth bronchial cleft cyst. So, and my last diagnosis is laryngomalacia. Clinically, there is history and also examination suggestive of the laryngomalacia, such as she had noisy breathing, which was worse on supine position, and there is also stridor with pectus excavatum. However, the point against the laryngomalacia is that they will not present soon after the birth. And typical natural history of the laryngomalacia itself also, it will resolve by the age of 2 years old. But in this child, we observe that the symptom worsened after the age of 2. And on endoscopic finding also, there was no typical finding of the laryngomalacia, which are number 1, omega-shaped epiglottis, short AE fold. Third, indrawing of the arytenoid during the inspiration. We did not observe all of these 3 findings during our flexible scope. And the last two is that usually in laryngomalacia, there will be no smooth surface lesion over the supraglottic region and also neck swelling.
Okay. Thank you, Dr. Azhar. So we've got 1 provisional diagnosis, which is vascular malformation, and 3 differentials, which are benign tumors of the larynx. And then you also thought about branchial cyst as well as laryngomalacia. So what investigations that you would like to request to further narrow down your diagnosis or even confirm your diagnosis?
Okay. Thank you, Prof. Mawada. So in this case, the preferred options of investigation is imaging. So I would like to get the Doppler ultrasound because number 1, I would like to know whether this is solid or cystic lesion.
Okay,
Clinically, it looks like cystic because it's a soft on palpation. And then number 2, because my differential is a vascular malformation. In vascular malformation, it can either be a slow flow or fast flow lesion. So by doing the ultrasound, I can basically narrow down my differential by knowing whether this is slow or fast flow lesion on the Doppler ultrasound. Number 2, I would like to get the magnetic resonant imaging of the neck, in which the MRI of the neck will help me to see the extensions of the lesion, as this is most likely to be a soft tissue lesion, so it's better to be visualized in the MRI, and MRI also will help me to see whether this is a macrocystic or microcystic lesion, and also as its relation with the surrounding structure, particularly in the neck. For example, our major vessel in the neck, which is the internal jugular vein and also carotid artery.
So Dr. Azhar, why would you request for an ultrasound first prior to the MRI? So from your description, you can get more information from the MRI, right? So why don't just perform the MRI?
Okay. So number 1, ultrasound is easily available in all the center. We can get it done within the same day compared to MRI. Sometimes MRI require more time because of the appointment. So that the most important reason is that it can direct our management. By knowing whether this is a slow or fast flow lesion, it helped me to know. For example, if it's a fast flow lesion, it's most likely from vascular origin, and we may need to order MRA instead of the MRI itself.
Okay, so good point there, but I think additionally in this case, because the patient presented with symptoms suggestive of upper airway obstruction, so it's difficult to perform MRI for a child. You need to perform MRI under general anesthesia, and to secure the airway in this child is a headache. So you tell your anesthetist you're about to intubate a patient who has a mass obscuring the view of the vocal fold, they pengsan already. So you need to have a good multidisciplinary team meeting consisting of the pediatric ICU specialist, and then you also need to have the anesthetist and the ENT surgeon, so that we can have a good airway plan for the patient for us to proceed with MRI under general anesthesia. So that is why we need to have ultrasound first in this case. Okay, thank you, Dr. Azhar. So I think I would like to invite Associate Professor Dr. Faizah Muhammad Zaki to present the radiological findings for this patient.
Okay, Assalamualaikum warahmatullahi wabarakatuh. Very good morning, everyone. Thank you, Aida, for that very excellent presentation. I totally agree with him in the sense that, you know, having to have ultrasound, pediatric radiologists like ultrasound because it's very readily available, no radiation, that's most important, and it's very children friendly. Okay, so thank you to the ENT department for the invitation. So let us start with the fact that, you know, the request of an ultrasound. So what we actually see on the ultrasound is basically quite an well-defined lesion, well-capsulated, but it is of multilobulated. So you can see one lesion here, another lesion here. This is at the region of the left neck. So what we do is that we put the probe at the neck and then we scan. So at the same time, we'll be able to see the vessel. Okay, so this is the vessel. And when we turn on the color Doppler, so the vessel light up, but the lesion does not give any evidence of a Doppler signal. So what does that mean? So it's either this lesion is not it's not vascular lesion, but as Adha mentioned, that some of the vascular malformation, for example, the lymphatic malformation, can actually have a slow flow Doppler. So we still put that as our differential diagnosis, but the echo texture, the texture within the lesion itself is quite heterogeneous. So most of the time, the lymphatic malformation is either will have cystic, which is very black, or it can also have a blood, it can bleed, then it can sort of like produce this kind of ultrasound findings. So therefore, our differential diagnosis will still be a complex lymphatic malformation because it already has some bleeding inside. And because it's also a slow flow. So if let's say we see a very vascular lesion, then we definitely go with a more high flow vascular malformation, for example, an atriovenous malformation. So in this case, it's not there, so we can exclude that. Another differential would be complex benign cyst. So it can be dermoid, it can be epidermoid, it can be the branchial cyst as well. Multiloculated abscess, but the child is well, right? So, and it has been there for quite some time. So, that will be low in your differential. Neurogenic tumor is not common, so that's why I put it below. But of course, I would totally agree to do MRI for our subsequent because we do have a mass lesion here. So this is the MRI that was done, was performed after the ultrasound. So what we see is that, so this is a T2, all these are T2 sequence. This is a T1 fat saturation because our face has a lot of fat, and we need that for us to have a post-gadolinium afterwards because we want to make sure anything that let up on post-contrast would actually be because of the lesion, not because of the fat, because fat was so bright on T1. Okay, so this is T2. So you can see that there's quite a huge lesion. So this lesion, as you want to correlate with the laryngoscope findings, the scope finding, you can actually see that the mass occupy the left area epiglottic fold here. So this is at the region of the base of tongue, yeah. So this is the base of tongue. Then you can see that, you know, the airway has been displaced more towards the contralateral side. It also occupies the left neck region. And encasing or insinuating, I would say, because it does not cause any compression to the left common carotid artery. Okay, so that's the left common carotid artery. This is the sternocleidomastoid muscle. So so it has been bounded more laterally by that muscle, but it has not infiltrating it. As we go down, this is at the region of the glottic infraglottic. You can see that the lesion does extend below, and it goes down, and it touches the region of the superior thoracic mediastinal area. Okay, so this is on the corner as if you are looking at the patient from the front. So you can see that this is the lesion. It displaces the airway more to the right side, and that's the common carotid artery that's been encased but not compressed by the lesion. And the lesion actually goes superior to the superior mediastinum because this is the area of the arch of aorta. So it's quite low in terms of the extension. So what do we see in this lesion? By description of the lesion itself, it looks multilobulated, if you can appreciate that. Okay, and then this lesion also, you can see that from, let's say we have one lesion here, there's another signal that is of different signal. It's supposed to be T2 hyperintense, very bright, but within the lesion itself, it has something slightly darker. Okay, it's T2 hypointense, what we normally describe. So this is a T1, no contrast, and we give contrast. After that, very heterogeneous enhancement, but the enhancement, if we relate, it's actually the one that is T2 black is the one that enhances. Okay, so this is basically the one that I showed earlier. So on the MRI neck of gadolinium, we can see a multinodular lesion occupying the left neck space that extend to the superior mediastinum. So MRI can actually show the extension very well. You see that it's insinuating the vessel, but otherwise it's the vessel are patent. Okay, and this is what we call the target sign. So T2 hyperintension with a center that is hypointense on T2. So this is quite typical of a plexiform neurofibroma. So for a lymphatic malformation, we do not have any target sign. We should have a very, hyperintense, very wide area of multilobulation, and you need to see it as a wall enhancement, like in this case. This is another case, not this patient's case. In a venous malformation, on the other hand, we know venous malformation is a venous leg, so it should have enhanced. So for example, it should have enhanced, and you should see some phlebolith within the lesion. So therefore, on MRI, we are quite confident that this is actually a plexiform neurofibroma and not a vascular malformation. Okay, I will be back soon afterwards. Thank you.
Thank you, Prof. Faizah. So now we continue with the progress of the patients after we have done the imaging. So in order to confirm the diagnosis, we need a biopsy. So however, in this case, as we all know, she presented with upper airway obstruction. We decided to for the patient to underwent tracheostomy under general anesthesia. This one is to secure the airway in view of the obstruction over the supraglottic region, followed by direct laryngoscopy and biopsy of the left airy epiglottic mass, and also ultrasound guided true cut biopsy of the left neck swelling. So intraoperatively, there was multiple firm lobulated mass palpable at the left level 2 and 3, measuring about 4 times 4 cm and mobile. And on the following that, we also have done ultrasound guided true cut biopsy over the swelling itself. So in this case, however, as we all know that the child has symptoms presented with upper airway obstruction, during the surgery itself, our anesthetist team managed to intubate the patient by using a video laryngoscopy, CMAC. So we managed to secure the airway first prior to the tracheostomy. So now I would like to show you the intraoperative image during the direct laryngoscopy. So to orientate all our audience here, so this is the anterior part. You can see the anterior epiglottis here. This is the posterior. This is the left side, and this is the right side. So you can see a huge smooth surface mass arising from the left airy epiglottic fold, and on palpation, it is firm. So in view of this lesion appear to be submucosal, it is not fungating, we proceed with the incision biopsy of the lesion. Post-operatively, she recovered well with no complication from the surgery, and in the ward, we have referred to the pediatric neuromedical as well as the ophthalmology team in order to assess for other systemic involvement of the neurofibromatosis. And upon further history by the neuromedical team, they have found that this child had family history of neurofibromatosis type 1 from the grandparent of the maternal side. And otherwise, from the ophthalm team, there was no evidence of ocular manifestation of the neurofibromatosis, and she was diagnosed with a neurofibromatosis type 1. So now I would like to invite Prof. Suria Hayati to reveal the histopathological result from the sample taken intraoperatively.
Okay, thank you, Dr. Azhar. Okay, so now you will see the histopathological findings of the biopsy of the left neck swelling and arytenoid mass. Okay, we skip that. So we received two type of specimen from this patient. The first is labeled as left neck swelling biopsy, and this specimen is composed of one small fragment of tissue, which we entirely submitted for examination. And the second specimen is labeled as left arytenoid mass biopsy, and this specimen is composed of two small fragments of tissue, which we also entirely submitted. Okay, both specimens show similar morphology. Therefore, I will show you only one pictures from the specimens. Okay, so as you can see here, this is the mass, and this mass form multiple nodules. Yeah, small nodule within the large mass. Okay, and the nodule vary in size, and it shows a complex or plexiform growth pattern. Okay, on higher power view, the tumor is relatively hypocellular, not that cellular. And you can see the tumor cell is bland looking, uniform, and it's spindle in shape and show wavy appearance. And the background stroma is myxoid, which means it's slightly purplish in color. Okay, and again the you can see the tumor cells is uniform. There is no nuclear atypia, which tells us this is a benign lesion. Okay, there is no mitosis and no necrosis scenes anywhere in the tumor cells. Okay, so again very bland looking tumor cells, and here you can see ganglion cells. Here. Okay, to confirm the origin of the tumor, we need to do immunohistochemical study to confirm. So, what is immunohistochemistry study? Okay, immunohistochemistry use antibody, okay, to detect antigen that is present on the surface or inside the nucleus of the cells. Okay, so if there are antigen present on the surface or inside the nucleus, the antibody will bind to the antigen, and this will give out a colored product. Okay, and we will know which cells that the tumor originate from. Okay, however, we must also know that aberrant expression can also be seen in tumors. Okay, not necessarily normal expression. Okay, so positive antigen antibody reaction will give out a colored product, with usually it is brown in color. Okay, in the background of blue. Blue is the hematoxylin counter stain, and if the antigen is present, if not present, the antigen will remain blue, as in this picture, picture B. And pathologists will be able to determine the origin of the tumor based on the interpretation of panels of antibodies used to stain the tumor. So we can tell the origin of the tumor based on the immunohistochemistry study from the antigen antibody reaction. Okay, in this case, the tumor is positive for S100 antigen. Okay, S100 usually present in cells of nerve cell origin, of nerve origin, and positivity can be seen in neurofibroma, schwannoma, and malignant peripheral nerve sheath tumor. Okay, this tumor is negative for Dasmin. Why we perform Dasmin? Because muscle tumor can also show a spindle cell morphology. So that is one of the differential that we should exclude. Okay, so as a summary, this is a tumor that show a complex multinodular pattern, relatively hypocellular, and the tumor cell looks benign, without cytologic atypia or mitosis or necrosis, and it originates from nerve. Okay, this is a differential diagnosis that you should entertain of nerve origin. Okay, this is our tumor. It shows a complex plexiform growth pattern. Okay, this is a cutaneous neurofibroma, which you can see just a single nodule, and is composed of very very bland looking spindle cell proliferation. There is no complex growth pattern. Okay, this is a normal nerve bundles. Okay, wavy spindle cell shaped nuclei. Okay, this is a schwannoma, which we can see in schwannoma, there are hypercellular Anthony A area and hypocellular, this is the hypocellular part here, down here, which we call Anthony B area, and we can see verrucate bodies inside the hypercellular area. Okay, the tumor in this child do not look like this, yeah? Okay, this is a malignant counterpart of nerve sheath tumor, which is malignant peripheral nerve sheath tumor. In MPNST, we can see the tumor is hypercellular. Okay, and we can also appreciate nuclear atypia within the tumor, and of course, we will see increase in mitosis and some areas of necrosis. Okay, so finally, we interpret this tumor as plexiform neurofibroma. There is no malignant transformation seen in this mass. Okay, thank you.
Thank you, Associate Professor Dr. Suria Hayati. So I would like to invite comments or any questions from the floor at this point. I can only allow one. Okay.
Thank you for the discussion for both. Interesting that we have a diagnosis of neurofibroma on histology. And maybe to Prof. Faizah, is it possible to differentiate the nerve origins of the tumor, like you're talking about neurofibroma, we talk about schwannoma. So based on the MRI, is it possible to distinguish these two? Thank you. Because in terms of surgery, I mean, if it's operation, then it will be a bit different in terms of approach. Thank you.
Okay, thank you very much, Prof. Razif. So, differentiating neurofibroma versus schwannoma on imaging, there are some features that can differentiate. For example, the target sign, because the target sign is more typical of a neurofibroma rather than schwannoma. But the thing is, sometimes it can overlap. For example, the shape, it can be a fusiform kind of findings. And then let's say the neurofibroma is only one. Okay, then it's actually at the periphery, so we can't really differentiate between neurofibroma versus schwannoma. I think sometimes we won't be able to do so. So HPE is the one that can differentiate.
Thank you.
Thank you, Prof. Faizah. Okay.
So now we continue with the progress of the patients. So she was discharged on day 10 post-surgery after we have done tracheostomy tube change to uncuffed Shiley tube size 4, and after parent has learned on the tracheostomy tube care and confidence to take care of the child at home. So now I would like to invite Professor Dr. Goh Bee See to continue on the discussion of this case. Thank you.
Thank you, Dr. Azhar. Thank you, Prof. Mawada, and team members who actually helped in the diagnosis of this child. So we can see that the final diagnosis is a head and neck plexiform neurofibromatosis, which is an NF type 1, and it involves larynx and also the parapharyngeal space and extending towards the mediastinum. So with the tracheostomy care, they can go home, but then what to do? The question is what to do with the treatment. We can do nothing, that means observe. Would the tumor grow? Surgery. So we have head and neck surgeons here. But how much can we cut? We cut the larynx. What will happen? Okay, and how to reconstruct the area. Radiotherapy, not sure about response for neurofibromatosis because histology, there's no malignancy. And also the risk of malignancy if the child had radiotherapy so early. Yeah? So we had a lot of discussions even with the overseas colleagues about what to do. Neuromedical felt that they have nothing to offer on medical treatment at the time, and they do not know whether it can grow or not. So at the end, we discussed with the colleagues in overseas and also with the parents, and they opted for conservative first, but scan surveillance, MRI surveillance. Because with surgery, as a surgeon, we can cut. But then I think when you have more grey hair, you will start think of not to cut, because the complications of surgery will be much more debilitating compared to not doing surgery. It was during COVID-19 pandemic, after they went back to Sarawak, they couldn't fly. So they had an MRI done in the local hospital, who actually did the first MRI for the child. And there was stable disease in 2021 and up to 2021, but unfortunately, during 2022, the report of the MRI said, hey, the tumor is growing. So what to do? So I think that's where I need to invite Prof. Faizah back to us to explain to us.
Thank you, Prof. Goh. I'm coming back. Okay, sorry. Okay, so this is the selected MRI sequences that we have 2019, 2020, 21, 23. So if you can actually see that now, I mean, in fact, coming to 2020, the mass has already encroaches and then causing further narrowing to the airway. But if you see the AP diameter compared to 2019, it slowly has becoming more and more, and then it has actually now displacing or pushing the base of tongue more anteriorly. Okay, and then the fact that we have the parapharyngeal left parapharyngeal and the neck component has also grows more bigger, and you can see that it is more bulky compared to the previous one. So as we go more lower down, so this is at the region of the glottis at the vocal cord. You can see that the mass has already a component at the left paraglottic. But now the more lateral one has actually growing more bigger, and then it can give some mass effect also to the adjacent structure. So this is how it looks like on the coronal. I mean, the distribution craniocaudally looks pretty much the same. It does not extend further into the intracranial or any lower than the one that has extended in the superior mediastinum, but we believe that the extension is more of the width extension as well as the anteroposterior diameter. I would like to highlight that there's another findings with regards to this patient that has grown upon time. So this is at the region of the brain. So this is at the region of the basal ganglia. So this is the frontal horn of the lateral ventricle, occipital horn of the lateral ventricle. So this is the thalamus, basal ganglia. You can see there's a lesion here at the region of the basal ganglia. And this is lower down at the midbrain. You can see another lesion, few lesion, and the hippocampus is also swollen on this side. Patient does not have any neurological symptom. Okay, so and upon 2 years down the line, the lesion grows bigger. Okay, so what is this? So this is actually focal areas of signal intensity, phases. That previously we radiology, we do not anything, we call it UBOs, unidentified by object. But what you see is basically on histology is a glial proliferation. And unfortunately, we don't biopsy this kind of cases, but it is very highly associated with neurofibromatosis type 1. Okay, so the course of the lesion itself is that it will increase in size, it will increase in number, until puberty. So the child is just up to 5 years old, right? So the lesion will increase in size, will increase in numbers, but then it will regress after puberty. Okay, so I think just a short one. So just to show you that the image of the plexiform neurofibroma, again I repeat the radiation-free technique, and of course we can compare differentiate with the differential diagnosis of vascular malformation. But still, MRI will still be the best. But CT scan, because it involves radiation, I think medical student, whenever we give lecture, things that relate to radiation, we will give this logo. So I hope that you are very aware of this is a radiation related imaging modality. But the lesion, it does not characterize the lesion any further. So it can help you in terms of the bone extension, but not the lesion itself. So definitely MRI is the key. It is the reference standard. The target sign I mentioned earlier. So you have a brighter peripheral and darker central. We call that as target sign. radiology have a lot of signs. It's basically correspond to the histologically of a dense central stroma, collagenous, with myxomatous tissue. But it's not very specific for neurofibroma, but it's most commonly seen in neurofibroma. So I think in radiology, we'll be able to diagnose all this and of course, knowing neurofibromatosis type 1, they can present with tumors. So definitely we can do a whole body MRI to view that. Yeah. So yeah, we'll be back soon. Thank you.
So you need to be very good friend with your radiologists because you need them to help you in the management and also to get the early MRI. Okay, so what happened, what you can see from the imaging is actually increasing in size, but we are unable to scope the child because child is away. And during COVID pandemic, nobody wants to scope a child with tracheostomy, already have airway. If you can follow me, this is the airway epiglottic fold mass that has increased in size and have difficulty to view the vocal fold. Again, so that is the tongue-based area, posterior, anterior, the mass. All right, so just have to believe me, it's difficult to see. So treatment plan, what else can we do? Somehow on literature search and discussion with friends as well as the parents looking for the type of treatment, FDA approved selumetinib for neurofibromatosis type 1 who are symptomatic and also inoperable. There's the word inoperable plexiform neurofibromatosis. This was approved and the name of selumetinib is Koselugo. This is actually a MEK inhibitor because MEK inhibitor components are activated in different type of malignancy. The good news again, Malaysia in KKM, they have approved the use of Koselugo in 2023 April 6. So we discuss with our pediatric colleagues and parents again because Koselugo have to buy, have to pay, and then the child had a full body MRI. There was no other involvement except the head and neck. So with the swelling which is increasing in size, the parents actually at the end agree. Yes, they wanted the treatment. And good news is minimal side effects. The main side effects is rashes, which is reported in worldwide as well. The neck swelling reducing in size. So I would like to highlight actually during the progress, the neck swelling become firm and firm. So the swelling has reduced in size and also become softer. I think Prof. Faizah, you want to show that volume reduction because something that we must call back because she said we'll be back soon.
So I promise that. Okay. So this, I think that the highlight is this 2024 because comparing with the 2023, but I still want to show the 2019 because the fact that, it looks like it's the AP diameter of the lesion actually has reduced and it's more or less comparable to the one in 2019. So this is at the region of the base of tongue, and this is at the region of slightly low at the region of the subglottic. You can also see that now the lesion has no longer causing narrowing to the subglottic region. So that's the coronal. You can appreciate that the bulkiness of the lesion has reduced. And just to show you, so this is the tracheostomy. That's the component of the superior, the thoracic inlet, but it's not much different from the 2019. And what happened to the fasci? So the fasci continues to grow. So it becomes slightly bigger, and you see more at the pons as well as the middle cerebral peduncle. Okay. So the thing about fasci is that somehow when they evaluate children that with NF1 that had treated with selumetinib, fasci would not regress. Okay, but what we actually see is actually it progressing. But if they have a control patient that doesn't have any selumetinib on board, but they don't see any progression. Okay, but we know that NF1 has associated low-grade glioma, and with the low-grade glioma, somehow it does not show any progression. So I think that's a good news, but but somehow FASI doesn't like selumetinib. Thank you.
Thank you for Faizah. So I learned FASI, I learned UBO. Okay, so we started on selumetinib on the MRI surveillance and also the blood assessment by our pediatric colleagues. You can see actually the swelling reduce and become softer. You have to trust me. So what to do? There's no standard protocol on this. According to the literature publications, the selumetinib has improved quality of life and also reduce volume reductions of the tumor. It may ease later on the surgery. So all these are possibility for future. But the treatment will be continue for at least a year, and we will reassess again on the clinical and on the MRI. So that's about the case. For the sake of medical students, I want to highlight before you go, when we talk about pediatric stridor, in this child, she has inspiratory stridor. When you have inspiratory stridor, usually the obstruction is at the supraglottis, like this child. Of course, laryngomalacia is one of the possibility. So when you say stridor, the causes you must think about whether you want to divide it into congenital or acquired for my postgrad, febrile or afebrile stridor. So these patients falls into afebrile stridor. In the congenital group, there are a lot on the list. Common one, yes, laryngomalacia, it should look like this. And laryngomalacia shouldn't have mass lesion. There's no mass lesion. Subglottic stenosis, many, I don't want to say, but you can see the mass can be a cyst, congenital cyst. In the acquired group, commonest is iatrogenic, the vocal cord intubation injury in subglottic stenosis. In the infections group is croup, more common in young children below 3. And in this patient, she has the neoplastic tumor, which is one of the rare things. In a history of patient with stridor, evaluate the case thoroughly, and then you must know whether you have time to further evaluate or you need to secure the airway. Okay, so need to get all the history. I think Dr. Azhar has mentioned all these things. The cry, if it's weak cry, you got to think about web, laryngeal web, and any previous history of intubation. So this child didn't have any history of intubation. If it's fever, it can be acquired cause, but it may also reveal the congenital cause. So the warning sign or alarming sign, cyanotic attack, apnea, choking, feeding difficulty, which causing failure to thrive. This child actually has failure to thrive according to the birth, the weight. Examinations, full examination, investigation, it depends on the case. Don't order or request everything. So it really tailored to the case. And what about the scope? So we talk about, I think Prof. Marwan mentioned what can we do. So for ENT, we can do flexible scope in the clinic. And this is how a typical laryngomalacia should look like. Omega shape of the epiglottis. Mobile epiglottis, mobile vocal cord, sorry. The AE fold is short, if you can see later. You can see the curled epiglottis. Arytenoid sometimes can be fallen, abundant or redundant tissues fall into the inlet. So that is typical laryngomalacia, which is not in this patient. You listen to the cry, the stridor, and see. Not easy to scope a child, so you really have the patient. Not sure if you can see, it's actually a bilateral congenital vocal cord palsy. But this child was sort of like treated as laryngomalacia until the mother said, my child is not well for many months. She requested referral. So please refer. You can't. You see, we can see this in the clinic. So indication of endoscopy when there's severe stridor, worsening symptom, airway obstruction affect the feeding, the growth, and causing failure to thrive, or radiologically suggestive of abnormality. And another thing is you want to make a diagnosis. Your clinical history does not tally with something that in your common practice. So like this patient, you got to make a diagnosis. Management, again, according to the course, I can't go through all because intubation or tracheostomy, like this patient, we have to secure by a tracheostomy. All right, so a few minutes about NF type 1. This is NF type 1. It's a peripheral neurofibromatosis. It is autosomal dominant, may have skip lesions. This is the diagnostic criteria. So if we have this, the detailed history of the family, we probably make the diagnosis earlier. But the family didn't reveal until later on. The child actually fulfilled the diagnostic criteria for NF type 1. NF type 1 is very rare, especially in the larynx. Endolaryngeal neurofibroma, extremely rare. Only 0.03 to 0.1% of the biliary tumor of the larynx. But they present with common symptoms that obstruct the airway. Depends on the location, the features, treatment. Surgery depends on the location and the size. If it is small lesion, yes, you should remove it early. Because the complex case, you need to avoid physical and psychological consequences due to the surgery and also the disfigurement by the tumor itself. So a lot of discussion needed. And this is one of the literature showing if it's in the upper airway, stridor is common. Then you have the dysphagia and even the drooling later on. And it's common at the AE fold, 34%, then arytenoid area. This patient is a big girl. She is about 24 years old. So they actually debulk the tumor because they want to avoid tracheostomy. So these are the things that can be done for the plexiform. So the new paradigm, if it's inoperable, we can offer selumetinib. So take home message, laryngomalacia is the commonest cause of congenital stridor. But stridor in children is not always laryngomalacia. Up to 25% laryngomalacia has secondary airway lesions. So she may have features of laryngomalacia but shouldn't persist. And flexible scope is important as our first assessment in the clinic. Of course, you may need an endoscopic evaluation under GA. The child has neck swelling. Think further. If it's a neck swelling, you may need imaging with our radiologist to do the ultrasound and MRI. And plexiform neurofibroma is rare, but they present with common symptoms in children. Treatment, multidisciplinary team involvement, selumetinib is a new modality for children. So, stridor, refer ENT. Thanks to everyone, and special thanks to my HPKK team on this selumetinib treatment. Thank you.
Thank you to all the presenters, and please join me in with a round of applause to all the presenters since we have already concluded the CPC. Thank you everyone and have a nice day.